Okay, so it's an absolute delight to be here this evening with you all to our inaugural lecture series. And we've got two professors presenting to us this evening. And actually, I think it will demonstrate a really interesting, diverse approach to careers as nurses. Both professors tonight have a nursing background. And what's really important is that we have the opportunity to hear about the work that they do, to celebrate their road to becoming a professor, because those of us that have done that journey know how hard it is and how special this event really is. We also recognise that it's a really lovely opportunity to invite friends, family, colleagues along to that event. So we will take them as two separate lectures. The first is, starting us off this evening, is Professor Gwenllian Wynne-Jones. So Gwen is a professor of nursing in the School of Medicine. She's the Director of Research for the School of Nursing and Midwifery and has recently taken up the post of Chief Nurse Research Lead for the Clinical Research Network West Midlands. And immediately that gives you a sense of something quite different. Gwen trained as a nurse at the University of Southampton in 2000 and completed her BSc Honours in Nursing Studies at the University of Stirling in 2002. Her MRC-funded PhD was conducted at the Arthritis Research UK Epidemiology Centre at the University of Manchester in 2005. She joined Keele in 2005, and her research activities focus on examining the impact of health on work and how this can best be managed. She is particularly interested in the prognosis and management of musculoskeletal pain and other conditions commonly seen in primary care, such as mild mental health disorders. Gwen has developed a programme of research that has examined the impact of health on work and identified and explored the rates of GP certified work absence for a range of health conditions. She has investigated the difficulties in measuring and managing the health and work interface in the workplace and in primary care, and has been awarded 2 personal fellowships from the NIHR, postdoctoral fellowship and clinical trials fellowship. Gwen has a strong interest in research methodologies and has been involved in the design and conduct of systematic reviews, meta-analysis, qualitative studies, cohort studies, and clinical trials. So it's with great pleasure that I invite Gwen up onto the stage here to give us her presentation, Health and Work, Getting the Balance Right.
Thank you, Pauline, and I think I can probably skip over a few slides now that you've done that introduction, which is always a good start. So I am going to talk about health and work and getting that balance right this evening. I'm going to talk for about 25-30 minutes around that, but I thought I'd start with, Pauline's given me a good overview of my career. This was me in the first year of my nurse training, so looking much younger, much fresher. Probably wouldn't fit in that dress these days either. So I did that advanced diploma of adult nursing at the University of Southampton, and I chose that course because it was much more vocational and a lot less academic than some of the other courses available. As many nurses in the room will know, it only became a degree profession in, I think, 2012, so a long time after I did my registration. And I went off to Stirling, and my mum said, Southampton, my mum said, "I'm not having you bother those librarians." And she sat me down and taught me how to do a systematic search and how to critically appraise a paper. So it turns out I actually really enjoyed the academic side of things, partly because she taught me how to do it properly, and she is or was a medical librarian, so she knows what she's talking about, which was a good start. And I went on to Stirling and did my BSc Honours in Nursing Studies. Now, at Stirling, you could stay on for an extra year and get that honours degree if you did a research dissertation. So I did a study that I now know, and hindsight's a wonderful thing, was my first ever epidemiological study. It was a cross-sectional survey of student nurse stress and their coping strategies. And their coping strategies are exactly what you're all thinking that they are right now, I can tell you that. So that was my first research project, and I really enjoyed it. And I thought, actually, can I do this a bit more? Can I do this, take this a little bit further? So I thought, maybe I could do a PhD. I didn't even think about a master's, which was probably a foolish mistake to start with. But I spoke to a lot of people and I said, what about a PhD? Is this an option for me? And the overwhelming answer that I got was, nurses don't do PhDs. And I know that sharp intake of breath there, because there are many nurses in this room who have PhDs or are working towards PhDs and professional doctorates. We most definitely do PhDs. So that slightly put me off, and I did apply for a role as a staff nurse in trauma orthopaedics, which was my preferred area of working. And at the 11th hour, a bit of a spoiler alert, I applied for a PhD in epidemiology at Manchester University. And it was all about the role of trauma in the onset of widespread pain. So it kind of linked with all the things that I was interested in clinically, the impact of trauma, how we manage pain appropriately in those orthopaedic patients. But I didn't know what epidemiology meant. And I went to that interview and I stood outside. I'm always early. Everyone who knows me, I will turn up early, very early, my husband would say. But I always turn up early, and I thought, I better find out what epidemiology means. And this was the days when you used to get a Blackwell's bookshop at every university campus. So I'm not as silly as I look. I popped in Blackwell's bookshop, got the medical dictionary, looked up epidemiology and thought, I can do that. That'll be fine. And essentially, for those of you in the room who are thinking, I don't know what that means either, it's the study of health and disease in populations, which is really relevant to what we do in healthcare research in particular, and how we try and improve care for our patients, how we try and improve the services that we're delivering and the ways that we deliver those services. So I was really lucky that Manchester took a bit of a punt on me and offered me that PhD. And of course I finished that in 2005 and was really lucky again to join Keele as a postdoctoral research associate. So given I came from nursing, my PhD was epidemiology about trauma, very clinical. Why am I talking to you this evening about health and work? Well, we spend an awful lot of time at work. If you work full-time, say a 40-hour week, 8 hours a day, you're at work for about 2,080 hours per year. That's an awful lot of time. We've got pretty good health and safety in the UK, which has reduced the incidences of occupational injuries and diseases. They do still occur, but the prevalence is much, much lower. But we also have, and this data's 10 years out of date, so this number will be bigger, 15 million people living with chronic conditions in this country. And that impacts on their daily lives, but it also impacts on their working lives and their abilities to engage and participate in the workforce appropriately or as much as they would like to. And recent data from Office for National Statistics tells us we've got 500,000 people who are on long-term sickness absence, 500,000 people. And a lot of those people don't want to be on long-term sickness absence. They'll want to be getting back into the workplace. And you only have to look, I did a quick Google this morning, you only have to look at the news headlines. And just this morning, the news was telling us that the NHS is seeing its biggest ever sick leave and sickness absence issue that we've ever had. So we need to be looking at this, we need to be thinking about this, we need to be doing something. And that's all well and good, but you need to start thinking about why are we working. So to help people back to work, to support people back into the workplace, you've got to start at why we're working. What does work bring to us? And I'm going to caveat what I say this evening is that what I'm saying will apply to most people. It won't apply to everyone. For most people, work brings a financial benefit that allows us to meet our needs and our wants. That doesn't apply for everyone, I have to admit, at the moment. Work brings us with structure. We're creatures of habit. If you work a 9 to 5, maybe even if you work a shift pattern, work brings that structure to our day. So that's helpful for us. It gives us our identity. We talk a lot about professional identities, but work brings an identity. And one of the first things people will ask you when you meet a new person, what do you do for a living? What do you do with your time? And work can give you that sense of identity. but it also brings meaning to people's lives. And particularly when you work in the caring professions, like many people in this room do, it really does bring a sense of meaning, that you're bringing a value and you're doing something useful. But it also brings our relationships, our social interaction with our colleagues. And it's lovely to have social interaction with so many colleagues tonight. So why is work important to our health? Well, back in 2006, Gordon Waddell and Kim Burton wrote probably the seminal report, Is Work Good for Your Health and Wellbeing? Short answer is yes. The longer answer is good work is generally good for physical and mental health and well-being. And they very carefully chose that phrasing, good work is generally good. So it comes back to that caveat. It's not the same for everybody, but for most people, being at work is a good thing. And prolonged sickness absence, so being out of the workplace for a long time, is generally bad for you. It doesn't do your health any good, and it's much harder to get back to the workplace the longer that you're out of work. The obstacles become much greater, and the amount of support and the thought and the planning that goes into that becomes much greater. So we know that if you take time off work, you're more likely to be anxious, depressed. If you've got a pain condition, you're more likely to have pain, generally less motivated about life in general. But if you're engaged in work, you tend to have better mental health, improved general well-being, lower levels of pain and reduced pain recurrence, and also increased access to resources to cope with life's demands. And that could be financial resources, but arguably the social resources that work brings to you to cope with life's demands are really helpful. And we've all had a bit of a moan to a colleague when you're having a bad day. That's really helpful. And the reason that it works out like this essentially is that if you're off work sick, you tend to be at home. Your partners, your family are out to work, they're out to school, they're out to university, whatever it is they're doing. You're at home on your own, so that element of social isolation starts to kick in. If you're at home, you tend to not be so mobile, not so active. We're not going out and about as much as we would. So actually, physically, you're doing less as well. And it becomes a bit of a vicious circle, and you can quite easily see how the longer you're in that situation, the harder it is to get yourself out. So for the rest of the talk, I think it's helpful to have a bit of a context and look at the history of certified sickness absence. I've only got 2 slides because I realise this isn't everyone's cup of tea. It's quite a dull topic. But when I started my career, this was what you would get if a doctor certified you off work. And it was only doctors who could certify you off work. Predominantly GPs, but all doctors could legally sign this document. And it was essentially for accessing statutory sick pay or social benefits, or if you were fortunate, an occupational sick pay scheme. But if you look here, it's all about how you should refrain from work, how much time you should take off. There's nothing on there about what you can do at work. There's nothing on there about what you're capable of. It's all about what you can't do. That's quite a negative point to start from. But if you contrast that with the current fit note, which came into place in 2010, you can see that there are options to start considering what people can do in the workplace. And very recently, so a few months ago, or even just sort of towards the end of last year, more healthcare professionals can certify absence from work. So it's not just doctors, but it's also nurses, occupational therapists, some pharmacists, physiotherapists. And that's reflective of the fact that actually some of these professions are working more closely with the patients and can make those judgments a little bit more easily. But it's also reflective of the changes in primary care and the changes in how we access care. So we can directly see a physiotherapist. We don't need to necessarily go through a GP these days. So it makes sense to open this up. Now, there are issues with the fit note, and I can tell you now that most people don't use those boxes at the bottom. But it does make you think, and it is a step in the right direction to think about what people can do rather than what people can't. And I'd rather be a glass half full person than a glass half empty. So, going right back to the beginning then, and sort of back to where I started at Keele. So, I was really fortunate when I joined Keele to work with Professors Kate Dunn and Chris Main, and Kate's somewhere in the audience over there. So Kate had done a study where she'd recruited nearly 1,000 patients who had consulted with back pain in 5 general practices in North Staffordshire. So this was the Back Pain Research North Staffordshire, or BARN study. And Kate had done a lot of epidemiology around back pain, and many of you in this room will have read and used Kate's work and know what really good evidence that she's got around the epidemiology of back pain. But she handed me this data set and she said, we've got this question in there around work absence and work outcomes. We think it's important, we know it's important because we put it in the questionnaire, and those of you who do questionnaires know every question counts because we try to keep them as short as possible. And Kate had asked people, are they employed? And if not, what was the reason for them not being employed, including related to their back pain? If they were employed, were they doing their usual job, reduced duties due to back pain, or on sick leave? And we looked at that when they consulted their general practitioner and 12 months later. And when they consulted, of those that were unemployed at baseline, 37% of them said that was a result of their back pain. 37% of them were not working as a result of pain. So that's a huge number. It's a small study, but if you extrapolate that up to the number of people experiencing back pain, it soon adds up. And when you look at what people are doing when they consult and you compare that to where they're up to 12 months later, 95% of people were doing their usual job at baseline, were still doing that 12 months later. So staying active at work meant you could continue to be active at work. 33% of people were on reduced duties at both time points, so a third of people were still struggling at work 12 months later. And 15% of people had been off work. And again, these are very small numbers, but 15% of people experiencing back pain being on sick leave 12 months later soon adds up. And I think most of us in this room have probably experienced an episode of back pain. 15% of people are struggling 12 months on. So we thought then, okay, we've looked at what the patients are telling us through the Barnes survey. We know they're telling us it's causing issues for them. What do the electronic medical records tell us? Can we spot this? Can we look for trends in absence in the electronic medical record? And at the time, Keele held a large GP practice data set, so the SIPCA data set, which was primary care data based on consultations, aggregate anonymous data, and it allowed us to explore what was happening in consultations with general practitioners. And it also allowed us to see what happened as a result of that. So were people referred to other services? Did they get prescriptions? And for me, crucially, did they get issued a sick note as it was in those days? And we found we could track that data, we could look at that. And what we found was some very clear patterns by age and sex. So women experience more sickness absence than men, or are certainly certified more frequently than men. And it seems to peak in that sort of 45 to 55 age group, which is often the bit where we're caring for children, we might be caring for older adults, we've got a lot of things going on in your lives there. The sharp-eyed will see that really steep drop on the end. That's reflective of the retirement age at this time the study was done. We don't see that drop anymore because retirement ages are shifting and essentially more people are working for longer, often with chronic conditions fluctuating and struggling to an extent with that time. But we also looked at all the other conditions. We looked at what the reasons were for taking time off work. And these are sort of based on the codes that are used in general practice, and they more or less relate to the different body systems. And we found that actually mental disorders and musculoskeletal pain were by far and away the biggest contributors to work absence. They were the reasons people were taking time off work. So a huge difference there. And really recent data from one of my PhD students, Amardeep, who's allowed me to use the slides tonight, looks at first ever fit note. And Amardeep's found that actually in musculoskeletal conditions, we can see there's a bit of a downward trend in taking time off work as a result of musculoskeletal conditions. And there isn't much difference by age in that group there. But if you look at mental health, the difference is quite stark. So I think we've got a bit of a healthy worker effect in this sort of 56 to 66 age group. But if you look at the younger age groups, sort of the 16 to 35, you can see people are taking time off work more frequently. They're having their first episode of absence. And this is a problem because we know that the biggest predictor of future absence is past absence. So if you've been off work once, you're more likely to go off work again. That's likely to continue until eventually there's a risk of falling out of the workplace. So we also wanted to speak to our clinicians. What are their views on it? How are they managing health and work in practice? Because it's a tricky question quite often. And this study, we talked to 11 general practitioners and 6 physiotherapists. Our physios told us it's one of the first questions on our pro forma. We just ask, what's your occupation? And that's because they would often gear up their treatment or their interventions to regain the function for people to go back to work. You'll see we have a very different response from our general practitioners who said, I wouldn't ask directly because I wouldn't say, oh, well, do you want a fit note then or a sick note? And that's a very different approach. And the reason for that is when you look at what the general practitioners at the time this study was undertaken were doing, it's a dual role for us, obviously. We're responsible for someone's physical health, and this is the second role we have as a sort of gatekeeper, to incapacity benefits, and the two sometimes don't sit very comfortably. I think if we reran this study now and we included all the other professions who are now able to certify sickness absence, we'd probably find similar findings, that actually having that dual role, being that gatekeeper, but also being the patient's advocate, which is what we want to do as health professionals, are tricky. And of course, there's policies and penalties in the workplace that are outside of our control. Strict sickness absence policies are barriers to get people back to work. If you have an episode of a chronic condition, you try to go back to work, actually it doesn't work out for you, that's counted as a second period of absence, and you can be brought in on disciplinary procedures, you get back to work interviews, and it makes it really difficult and off-putting for people to go back to work. So why don't we refer people to occupational health? That seems like the simple option, doesn't it? And I think that's a good question, actually. And the reason that we don't refer people to occupational health is when the NHS was set up 75 years ago, I think now, occupational health was not part of its responsibilities. Employers were responsible for delivering occupational health care. And at the time it was set up, that made sense. If you're working in a factory or you're working in the mines, employers would employ a doctor to look after their staff. And the reason is they could directly see the impact on their bottom line of having someone off sick. So it made sense. But over the years, organisations have outsourced occupational health care, probably as a bit of a cost-cutting measure. And we're also seeing quite a lot of precarious and non-standard roles. So where occupational health care fits, when you're blurring the lines between home and work, also makes things a little bit difficult to manage. And we know that the majority of this country work in small and medium and micro enterprises. Only 10% of them have any kind of occupational health care available. And that will vary from your basic vaccinations and immunisations right through to a full suite of physiotherapy, psychological support, counselling. So there's really limited availability of occupational health care. So this is the problem as we saw it in Keele with myself and many others that I was working with at the time. People come into primary care with their health condition. It's difficult to manage that within that setting. You've got to do an assessment of the person's condition. You might have to do a referral. You might have to look at their prescriptions, just check they're not contraindicated with what else they're on. You might write a fit note. Your 10 minutes is up. You can't talk about health and work. You haven't got time to have that conversation where you think about all the different strategies that people need and the issues that they've got. So when people next have an episode of whatever their health condition is, the cycle repeats itself. And those absences get longer and longer and more frequent, and we're losing people. So we thought, well, what can we do about it? Can we intervene to address these occupational health issues, and can we get a faster return to work and fewer absences over the longer term? And the way that we went about doing this was the study of work and pain, or the SWAP trial. So we got 6 general practices. There's not a lot of science in this, and there's a lot of story, so there's no numbers. We got 6 general practices, and we trained 3 vocational advisors, and we put them into 3 of the practices, and we made sure that they were using the best evidence-based advice to support people back to work. 3 of the practices gave usual care, and our general practitioners could refer people who had musculoskeletal pain. They might have had some time off work, or they might be struggling with their work. And we followed them up, and we asked them at 4 months and 12 months, what are you doing for work? How's it going? And what we found was that most people, 82% of them, only had a telephone contact with our vocational advisors. That lasted for a median of about 13 minutes, but it ranged between 10 and 20 minutes. About a fifth of them had a face-to-face contact that lasted about an hour, and we had 1 workplace visit. So what we did was really light touch. It didn't take much. We weren't doing a great deal with these people. And we found the issues that they were coming with was symptom control, so their pain was not managed appropriately. They had perceptions about working with their pain that weren't quite right, so having to be 100% pain-free to be at work. I think probably quite a lot of people in this room wouldn't be here if we were 100% pain-free. I'm including myself in that. But also we found that they had a perceived, that there were perceived lack of modified duties at work. And when you asked them, they hadn't asked their employers whether there were modified duties. And when you prompted them a little bit further, they would tell you how they could do their job in a different way to achieve the same outcome. So they knew the answers. And we found that actually, in those people who went to see our lovely vocational advisors, over 4 months, they had about 9 days off work, so still a reasonable amount. But in our control arm, where they didn't see our advisors, they had 14 days off work. So that's a whole week's difference in sickness absence. Now, that was statistically significant. I look at the statisticians in the room, I've not put the numbers down. But arguably, that's way more socially significant. Because if I'm an employer and I don't have to cover that job with locums or with supply or distributing that across my other staff, I'm going to be happy. And of course, the health economics, which are a few numbers, were really impressive. So if you invest £1 in this, you'll get £49 back. So what next? Well, in partnership with our patient and public teams, our colleagues in other universities, government departments and charities that I've left off there, we've taken that SWAP trial, we've created the work and vocational advice trial, which takes our intervention and does it for everybody, not just musculoskeletal pain, because the principles are the same. We're giving them the same advice to get back to work. Very difficult trial, a lot of work still to be done around that one in particular. We've worked with our colleagues at Oslo Metropolitan University on their SVI trial, apologies for my Norwegian, and that looked at whether we could target our occupational interventions to the people who are going to benefit most. We've done training for healthcare professionals through the ISWAP study, where we embedded vocational advice and support in first contact physiotherapy services. We're part of the Centre for Musculoskeletal Health and Work, where we're looking at predicting work absence, so we, again, can better target support to the people who need it. And, of course, we've been working with our patients to create patient education resources through the backup programme, which is essentially a workbook online that patients can work through and plan what they're going to do when they have an episode of pain, so they know what to do when they're in that sort of acute pain moment. Well, if we go back to the beginning, nurses don't do PhDs. I'm on a bit of a mission to kind of scrub that out, and I think we're getting there, actually. I've been really fortunate to be able to take on roles as Research Director in Nursing and Midwifery, and also latterly as the Chief Nurse Research Lead. And in both of those roles, it's all about creating that research culture within the nursing, midwives and sort of non-medical professions, if you like. And we're doing that through demystifying research. You know, there's no silly question. I ask a lot of silly questions, if that's true. But it's demystifying research. It's giving people the opportunity to engage in research activity. That might just be searching the literature, which was how I started, thanks to my mum. It might be being able to use that evidence in your clinical practice so that you're doing better for your patients. It might be that we support you to write a paper or to write a grant application. And it's about supporting people to find their pathway in research, find their route through. Because I've come through a particularly traditionally academic route, and Sarah will tell you a very different route coming through in the next presentation. But being able to work with both the School of Nursing and with the West Midlands CRN has allowed me to really engage with nurses and to try and grow that culture. So we started with my journey into research. This is my journey through research. And I've put this one in because Helen Duffy always likes this slide. I'm not sure why. But essentially, a lot of what I've achieved has come later in my career. I've done the building blocks of the multiple different methods that we've done to look at health and work from all the different angles. I've been really fortunate. I've had an NIHR research fellowship for my postdoctoral work and also a clinical trials fellowship to really learn a bit more about how trials work in practice and what we can do. Now, there are big gaps, and two of those big gaps are sitting on the front row over there. So whilst it looks like I was not very busy in those middle years, I was actually quite busy. And much of what I've done part-time. I've only recently gone back to working full-time. So I talked a lot about getting people back to work, and I've not really mentioned the balance, and it's the balance that's really important, and I've got to remember my numbers now. We are at work for about 2,080 hours, but there's over 6,000 hours in a year. So we've got a lot of time left to get that balance right, and this is how you get the balance right. So you get the balance right with work by spending time with your family, spending time with your friends, do your social group, sing in the choir, which is what I do on a Tuesday night. Get into the outdoors, because particularly with an academic career, it can expand to fill the time that you give it. And if it expands to fill too much time, you will be going off sick yourself with burnout and all those other things. So it's really important that you do get that balance right, and you do fill your time with all these sorts of things. And we all need a little helping hand at the right time. And I always like this picture, because that tree is still a tree, isn't it? It's still providing shade, it's still a habitat for wildlife, but it has a helping hand to do that. And if you take that hand away, that tree will fall down and we lose all of the benefits that that brings. And that's exactly the same in the workplace, it's exactly the same at home in our personal lives. We all need a little helping hand at the right time, in the right place, to help us do what we usually do. So I've just got one slide of thank yous. I've had a lot of helping hands over the years, and I've had a lovely morning digging through the old primary care photo album. It's still available for those of you with access. And I've been really fortunate that I've been supported by a lot of people, many of whom are in the room this evening, actually, which is a nice surprise. And I've tried to get in pictures of some of the social events that we do, because work's not just all about work, is it? It's about social events. That one in the middle is when Christian decided to dress me up as a Christmas tree to try and win the tallest Christmas tree competition at one of our Christmas events. I'm 5'1". I am not going to win a tallest Christmas tree competition. And we didn't win, I can tell you that. So the final thank you that I've got is for you in the room, just to thank you for listening and joining me on this journey, many of you. Much appreciated.